Welcome. I'm Gordon Tomaselli, and I'm here with Dr. Mark Estes. We're coming to you from the American Heart Association Scientific Sessions in New Orleans, Louisiana. And we're reporting on a clinical study, clinical trial session called High Impact EP Registries and Clinical Trials. And Mark, it was kind of an interesting session. What caught your eye?
Well, there were two studies on atrial fibrillation that I think were important and were relevant, Gordon. The first one, the SMAC-AF trial, was an intervention trial for hypertension alone in patients about to undergo AFib ablation with two limbs, one with aggressive management of blood pressure for 6 months prior to the ablation, and the other one was standard therapy for blood pressure, so both limbs were treated. And at the end of the entire process, after follow-up in a relatively short period of time with very few patients, no difference with intervention with high blood pressure alone in terms of the primary outcome, which was AFib recurrence. Subgroup analysis indicated that if the systolic blood pressure over 140 over 65, there may be some benefit, but as always, you take caution with those subgroup analyses. So this is really not consistent with data we've seen come out of Adelaide with the Legend trial, in which lifestyle intervention, exercise, diet, and 10% body weight can have a dramatically favorable impact on patients with AFib, whether managed with lifestyle alone, ablation, or drugs. And we clearly need to investigate this further, but at least in this study with aggressive blood pressure reduction, no change in AFib outcomes after catheter ablation.
So as the discussant said, probably too little blood pressure alone, and maybe too late. The time between aggressive management and ablation was really pretty short, about 3.5 months on average.
That's correct. That's correct. So don't give up on lifestyle modification. A terrific talk earlier this morning by Amelia Benjamin about prevention of AFib, and I think it really is something that we all need to think very hard about in our own practices.
And you were the discussant for ASSERT-2. Tell me a little bit about what you thought about that study.
Well, yes, the ASSERT-2 trial was another important trial in which patients who had no clinical history of AFib were monitored with implantable loop monitors. And in this relatively high-risk group of patients, there was a high frequency of subclinical AFib detected. Now, they were selected based on age over 65, one other risk factor such as hypertension, diabetes, and also enlarged left atrium. And in this group of patients, fully 35% at 18 months had subclinical AFib detected. It was about 2.7% at 1 year that had 24 hours of AFib. So it adds to the growing amount of data that we have about subclinical AFib, which indicates that it can be found commonly in patients with risk factors for AFib. It is not entirely clear whether it is a marker of risk for stroke. It's not clear that intervention in these patients with anticoagulants decreases the frequency of stroke. But an important contribution because it shows that the frequency of AFib in this patient population is really quite high. Yeah. And it is one more piece of data that, in light of all the other trials that are ongoing, I think will help us to know what to do with this group of patients who generally are at lower risk for stroke with subclinical AFib detected by pacemakers, defibrillators, or loop monitors. So
it looks like AFib may be a signal, and there's probably something in the vasculature that says these people are prothrombotic in some way. It may be Chad's VASC score may not completely identify people who are at risk.
That's exactly on target here, Gordon. I think that that there are a number of interpretations of this and other data. One of it is that the AFib is causative. That's probably not in the case because the temporal relationship to AFib in many of the trials is very poor. There's a trial underway right now looking at actually anticoagulation to prevention of AFib. Right. So it may well be that in some patient groups the AFib is causative, in some it is temporally related, in some it is a marker, and it might be that they're all true. Mm-hmm. So we have a lot to learn about this, but it's a very large area of intense investigation right now with multiple trials.
Yeah. So I was struck by the post-SCD trial, which is a kind of a heroic trial that came out of UCSF, where in collaboration with medical examiners in town, they looked at every sudden death in the community and tried to adjudicate the cause. Obviously, a challenging thing to do, particularly with out-of-hospital cardiac arrest. And the cause was one of the not surprising things was that the cause of particularly presumed arrhythmic sudden cardiac death is not as much ventricular fibrillation as we would have anticipated, and I think that's consistent with data out of Seattle that suggested that treatable rhythms like VF seem to be less of a cause of arrhythmic sudden cardiac death. The other thing that was a bit surprising to me is that there are other causes of presumed sudden cardiac death that really weren't cardiac and were due to occult neurologic causes or, in fact, in this population in San Francisco County, occult drug overdose, and in particular narcotics overdose. Some of the data is surprising, but it really speaks to the notion that we really don't understand the epidemiology of sudden cardiac death, and I wonder whether or not really making this a reportable disease would help us get more data to make these adjudications, to really understand the epidemiology and the demographics of sudden death.
Yes, it was quite striking too, the low frequency of coronary disease in the patient population, only about a third of them, which is very different from what we see in other reports previously, but a highly selected group out of literally tens of thousands, the autopsies done in about 600 only. So a selected group of patients, but as has been seen before, the unwitnessed arrest, high frequency of asystole, but a lower frequency of VF in the witness arrest and more asystole as well. So very labor intensive, important study, but as Graham Nichols, the commentator, indicated, the demographics of sudden cardiac death vary widely regionally. So generalizability to other areas may not be clear.
Right, I would agree.
Yeah.
And then the final study was, I think, a very important one, and it had to deal with the newer oral anticoagulant drugs. And in particular, one of the issues that has really confounded investigators and actually stayed the hand of some, perhaps, is the absence of specific reversal agents. And in this case, reversal agent for dabigatran, daricisamab, was the follow-up data were presented. And this study was interesting in the sense that it confirmed the earlier presentation about this reversal agent, in that it appears to be safe, number one, and I think that's a high priority. It appears to be very effective in reversing, both by anticoagulation parameters and clinically, the effects of dabigatran, and it appears to act in a very timely fashion, minutes and maybe even seconds. So this is something that I think we need to kind of keep our eye on. It may, in fact, change the way people use oral anticoagulants and may promote a further shift from vitamin K-based antagonists to some of these newer drugs. And as some of the other agents develop or have reversal agents available, I think it's going to make practitioners feel a little bit more comfortable with using these agents, knowing that there's an out in the two groups of patients who may need to be reversed: those who are having acute bleeds, who may need to have that bleeding tempered by a reversal agent, and those who need a procedure of some kind that requires more control of coagulation.
The objective data there relative to reversal of the effect of the dabigatran was really very impressive, virtually 100% within a couple of hours. More difficult to interpret is the surgeons and other clinicians' assessment of the hemostasis, because it was not blinded. And in that respect, too, I think even though 93% of the patients had very adequate hemostasis at the time of their intervention, it needs to be put in the context of an unblinded study.
Right. Wasn't blinded, and it was adjudicated, not centrally, but locally at
locally,
each of the
that's
sites.
correct. So, yeah, so, but still the evidence relative to the objective assessment of reversal, and also actually we saw data on dabigatran levels, which were extremely low.
Right.
So the binding is immediate and effective in eliminating it. But still, many questions related to partial reversal, as came from the discussion afterwards. But an important piece of data, and so it turns out it's about 2% of patients on NOACs who do have major bleeds and whom you might want to reverse them. So it's a clinically important niche.
Yes. Maybe not changing practice yet, but perhaps a change in practice on the horizon. So I'd like to thank Dr. Mark Estes for joining me today. We're coming to you from the American Heart Association Scientific Sessions in New Orleans, Louisiana, 2016. Thank you very much.
Thank you, Gordon.